This is an addendum to segment 5 and 6. It's meant to simplify urinary incontinence and pelvic organ prolapse, especially bladder prolapse.
Stress urinary incontinence in women. Urine is produced in the kidneys and stored in the urinary bladder. Urination is the process of emptying the bladder through the urethra that connects the urinary bladder to the external urethral orifice. There are two sphincters, or valves, that keep the urethra closed to prevent leak. Internal urethral sphincter, located at the neck of the bladder, and external urethral sphincter, located right above the external urethral orifice and is supported by the pelvic floor muscles. When the bladder is full, stretch receptors in the wall of the bladder send a signal to the spinal cord in the brain. At times when it's not appropriate to urinate, the brain sends back an inhibitory signal to keep the sphincters closed and prevent voiding. When you wish to urinate, this inhibition is removed. The spinal cord instructs the muscle of the bladder, the detrusor muscle, to contract and the sphincters to open to let the urine out. In stress incontinence, small amounts of urine leaks when the person is sneezing, coughing, laughing, or having any activity that creates abdominal pressure on the bladder. This usually occurs because the pelvic floor muscles are weakened and can no longer support the sphincters. In women, this typically happens as a result of pregnancy, childbirth during which these muscles are overstretched. In most cases, this condition can be treated with exercises that strengthen pelvic floor muscles.
Over here we have the bladder filled with the urine in yellow. Over here we have the uterus. And over here we have the intestines and the rectum. Over here we have the vaginal canal. You'll notice over here that in front of the bladder there are the muscles which support the bladder. These muscles are very important in that these muscles provide all the support that's necessary to keep the bladder from leaking. And when these muscles are not doing their job, that's when you'll have incontinence. That's when you'll have leakage. The most common reason that the muscles become weak is childbirth, having children. Having children is a very traumatic task, and basically when a child has a large head that's coming through a vaginal canal, which is very small, you have trauma to the muscles. These are the muscles. When these muscles become traumatized, they can either tear, in which case you have incontinence the very next day, or they can just become weak. And typically that happens 10, 20, 25 years after having children, so that by the time the lady's 40 or 45, the lady is leaking urine, even 20 years after she had the children, because these muscles have become weak, and every year that goes by they become weaker, and at a certain point they cannot support the bladder. So over here we have the bladder with good muscle support, filled with urine, and when you have pressure from above, pressure means coughing, jumping, sneezing, laughing, dancing, having sexual relations, doing any kind of muscular activity, lifting anything heavy, pushing anything heavy. When you have that kind of pressure from above, the bladder does not leak because the muscles in this area are strong and tight and hold the bladder and give it good support. So with all that pressure from above, coughing, sneezing, laughing, etc., there's no leakage. Now, on the other hand, if these muscles become damaged, as you can see right here, if these muscles over here become damaged, then you do not have the support that you need to hold the bladder and to maintain continence. If these muscles become either torn from the trauma immediately related with childbirth, or become weakened over many years after childbirth, then there's nothing supporting the bladder, there's nothing holding the bladder, and when you have pressure from above, with coughing, sneezing, laughing, lifting anything heavy, pushing anything heavy, dancing, jumping, aerobic exercise, etc., When you have that pressure from above, you have leakage. The urine is coming out of the bladder because there's nothing to support it. The support here is lacking. The support is missing. So with pressure, you have what's called stress incontinence. Stress means pressure from above, usually related to muscle activity, coughing, sneezing, laughing, doing any kind of exercise, aerobics, jumping jacks, getting on a trampoline, doing any kind of aerobic activity, lifting anything heavy, pushing anything heavy, carrying anything heavy will cause urine to leak out without control because the muscle support that is essential is not there and it's lacking. The treatment for this is to replace the support that's not there because the muscles are weak. That we can do. And to replace this support, we have what we call a sling. The sling is an artificial material. It's called mesh. I like to call it tape because it looks like Scotch tape. The tape goes underneath the bladder and it holds the bladder muscles in place and it replaces the support that was lacking by the muscles which have been damaged from childbirth. When you have this sling or the tape in place, and then you have coughing, sneezing, laughing, jumping, lifting anything heavy, pushing anything heavy, all of the activities that normally would cause stress urinary incontinence, you no longer have incontinence because the sling or the tape is holding the bladder, giving the bladder the correct amount of support, so that now, with the sling in place, you will not have any leakage, you will not have any more incontinence, you can cough, sneeze, laugh, lift the grandchildren, lift anything heavy, push anything heavy, carry anything heavy. You could do aerobic exercises, bicycling, jumping jacks, Latin cardio, taekwondo, tabo. You could do any kind of exercise that you want, and there won't be any leaking because you now have the support that was missing from before. When the tape provides the support, the incontinence is corrected. Now, this is not the only type of problem that you can have related to the bladder and related to the vaginal canal. There are other types of problems that you can also have besides incontinence. And I'm going to explain those problems right now. If we go back to the normal anatomy, you'll see the muscles are here. This part is called the urethra, which is the opening underneath the bladder. In a woman, it's generally about 1 inch long. The urethra leads to the bladder. You'll notice that the uterus, right on top over here, shares some of the muscles that support the bladder. The uterus and the bladder are very good friends because the uterus is sitting on top of the bladder. So, very often after a hysterectomy, or just from aging in general with the uterus present, or especially with the uterus missing, these muscles over here can become weak. If these muscles over here become weak, the bladder will then change position and will fall. If the bladder is falling, we call that prolapse. We can grade that prolapse into mild, moderate, and severe. And this is what the prolapse looks like. Here's the bladder wall. And when the bladder starts moving into the vagina, you have this kind of a problem where the bladder is pushing in on the vagina. It can get worse, and this we would call a mild degree of prolapse. It can get worse. We would call this a moderate degree of prolapse. It can get much worse, which we would call a severe degree of prolapse, and the bladder can even fall outside of the body. Notice over here that the opening of the bladder is right here in the middle where we have the opening of the urethra. Notice that the urethra here is in the middle of the bladder. As you know, water likes to go downhill. Water has a problem when it's forced to go uphill. Water does not like to go uphill. Many women who have this prolapse problem feel that they're always full, that they're never empty, that every time they urinate, they have to go back to the bathroom 5 minutes later, urinate again, and there's always a lot more urine in there because it's never empty. That's because those women who complain of those problems may have a prolapse. The prolapse collects urine over here. This urine does not empty because it has to go uphill to empty. And urine doesn't like to go uphill, prefers to go downhill. Over here, you have a prolapse. The urine frequently fills this prolapse, frequently does not empty. So you have a bladder that's never empty, always partially filled. The bladder doesn't like that either. When the bladder is never empty, that leads to inflammation of the bladder. That makes it feel like there's a urine infection there. It makes it feel like you always have to go to the bathroom to urinate. And it makes it feel that no matter how many times you go to the bathroom, it's never empty. And the reason that it's never empty is because of this prolapse. This prolapse obviously has to be fixed. Now, some prolapses are not that severe. They're what we might call moderate. They may even be called mild. The mild prolapse does not have to be fixed. The more moderate one generally does have to be fixed. How do you know which is which? How do you know if you have a prolapse? We can ask you certain questions and you would tell us the answer. If we ask you, do you feel anything heavy in your lower area? And you say yes, that could be a prolapse. If we ask you, do you feel anything is falling down in your vagina? And you say yes, that could be a prolapse. If we ask you, do you feel a bulge in your vagina when you're cleaning yourself after urinating? And you say yes, you feel a bulge, that could be a prolapse. If you say during sexual relations, you feel that there's something banging into something that's not right, that doesn't feel normal, that could be a prolapse with the bladder falling into the vagina. All of these symptoms can represent a prolapse. If the prolapse is present, it has to be fixed. What do we do to fix a prolapse? We lift the bladder back into the normal position, and we put a second mesh in this area over here between the bladder and the vagina, a second mesh. In addition to the first mesh, which is stopping the urinary incontinence, or the first sling, or the first piece of tape, we put a second mesh underneath the bladder over here between the bladder and the vagina to hold the bladder in place. That we do if it's necessary, which would be a moderate or a more severe prolapse, and we would do that at the same time as we were fixing the incontinence. Some women don't have all of the feelings of prolapse, and some women can have a prolapse and have no feeling of the prolapse or no signs of the prolapse at all. That's why a detailed examination and bladder testing are important. Even after a person urinates, we like to know if the bladder's empty. If the bladder still has a lot of urine in the bladder after you're done urinating, we call that a high residual, which may be a sign of a prolapse. So we do investigative studies, we do x-rays, we determine with an examination if there's a prolapse present, and if there is, we discuss with the patient whether it needs to be fixed or whether it does not need to be fixed. If it's mild to moderate, it may not need to be fixed as long as the person knows that the prolapse is there, and in the future it might need to be fixed if it's going to get worse. If it's mild or severe, obviously that would need to be fixed at the same time as the incontinence. Many women have prolapse and have varying urinary symptoms of the prolapse. They feel that they always have to go to the bathroom in a hurry. They feel that they can't get to the bathroom fast enough. They feel that if they don't get to the bathroom right away, it's going to leak without their permission. We call that urgency and urgent continence. Those may or may not be signs of a prolapse. We have to investigate that. So there may be overlap between the urinary problems of incontinence, which we call stress incontinence, which is incontinence due to coughing, sneezing, laughing, lifting anything heavy, carrying anything heavy, pushing anything heavy. There may be an overlap between that incontinence plus the sense of urgency and urgent continence, where the lady has to run to the bathroom in a big hurry and does not get there fast enough. And if she cannot get there fast enough, the urine is coming out without control. Those may both have to be fixed, both the stress incontinence and the urgency incontinence. If there's stress incontinence, we put a tape over here. If there's prolapse, we lift the prolapse and we correct the prolapse as well. Most people just have stress incontinence. In my patients, 2/3 of them have stress incontinence by themselves, and only 1/3 of the people with stress incontinence have the urgency or the prolapse at the same time. So this is the situation that you're having with prolapse, where the bladder is falling into the vagina. And apart from that, You also have the straightforward problem of urinary incontinence, either with these muscles becoming very, very weak, which takes 20 years after childbirth, or with the muscles tearing. And if they tear, if the muscles tear, you have the problem of immediate incontinence, which can happen the very next day after having children. And some women report that the baby, the newborn, is wearing diapers, and then mother has to wear diapers as well. Only problem is that the baby will outgrow the diapers, and mother will not, because the muscles that support the bladder have been damaged during childbirth. This is not very common, but it does happen. More common is that the muscles just become weak 10, 20, 25 years after childbirth, and that weakness of the muscles allows the urine to leak every time there's coughing, sneezing, laughing, muscular activity, exercise, aerobic exercise, jumping jacks, any kind of muscular activity would cause this leaking. That's called stress incontinence. That's what we fix with the sling or the tape that goes around the bottom of the bladder, so that when there's coughing, sneezing, laughing, and exercise and lifting heavy objects, there's no more leaking. This is a procedure which generally takes us 15 minutes, done in an outpatient setting. We can even do this procedure directly in our office, in our own surgery center, which we'd be very happy to have you come in and take a look at.
Thank you.